overnight procedure. In some patients with Dent syndrome, with neurological features, insulin therapy cessation may not be possible. It is also fair to say this to the family. And however, there is also a hope that in subjects with intermediate Dent, with some, I would say, less severe neurological abnormalities, in whom the transfer was possible, some improvement in neurological function may be expected. And a few groups in the world describe this, and one of them is a group of collaborators from this country, headed by Professor Młynarski and his group. And a geneticist, however, a geneticist or a diabetologist should be very careful during the initial counseling for Dent and iDent PNDM patients in order to avoid generating unjustified expectations. It was quite obvious that as mutation occurred within these subunits, as shown here on this slide, that we, clinicians, geneticians dealing with this research had to try the switch, as sulfonylurea binds to this red sulfonylurea type 1 subunit. And it was described and published in the paper in New England Journal of Medicine that indeed this switch is possible, and not only those individuals are gaining a better quality of life, but also HbA1c level improves. So this is truly wonderful situation. Not only their life becomes easier, but also their diabetes control improves. And this is one of the CGMS records performed in one of our patients. Actually, this was one of the patients from the collaborating pediatric centers. However, this gentleman was able to abandon insulin therapy, probably abandon insulin pump therapy, give this device to somewhere to the other patient, and he's currently living absolutely normal life from the point of view of glycemic control, just taking 2 or 3 sulfonylurea tablets in the morning every day. The important question is, how long will it last? And the true answer is that we are not quite sure about that. I'm showing you the data that we published last year, and you see that after 3 years of such treatment, essentially we do not see any worsening of glycemic control. Moreover, we were able to decrease sulfonylurea dose, which was pretty high at the very beginning, and we think that this is very encouraging, and we hope and we keep our fingers crossed that this will last for the entire life of the patients. I mentioned that usually we are dealing with diagnostic testing. However, we described last year a case of a pregnant woman with KIR 6.2 mutation, where we indeed performed prenatal genetic testing. However, we should frankly acknowledge that we did not perform this testing purely or even mainly for the PNDM causes. This lady was above 35 years of age, and also on UCG in utero in the child there were some suspicions of Down syndrome, so we did prenatal testing for that causes. However, we were not able neither to confirm trisomy, which was very fortunate, and also we excluded PNDM mutation. What is also important that for the majority of the pregnancy period, we were using sulfonylurea, including the organogenesis period in the first trimester. Simply, the pregnancy was unplanned. And I have to say that this lady became pregnant for the second time, and she refused the switch from sulfonylurea to insulin, and during the second pregnancy she was for the entire period on sulfonylurea. And so far as I know, because she lives in northern Poland, the child is doing okay. Although we should acknowledge that there were some hypoglycemic episodes soon after the delivery in both children. So the people should be aware of that. The second gene that should be screened is the proinsulin gene encoding insulin. And the arguments, this is the second most frequent PNDM cause. And again, the cost of sequencing is quite limited. The proinsulin gene is also quite small, so this is again for us here in Poland, and I think that still in some other countries in Europe this is quite important. However, we should be aware that as the underlying mechanism of insulin gene mutations lead to irreversible beta cell destruction, and attempt to interrupt insulin treatment and to start oral hypoglycemic agents, for example sulfonylurea, is not justified. It was already said in Professor Młynarski's lecture, and this information should be given to the patient and to the family. The next gene is ABCC8 gene encoding sulfonylurea type 1 potassium channel subunit, and the arguments for that is that this is the third most frequent cause of PNDM. However, this gene is much larger and its sequencing is laborious, time-consuming and costly. This should be screened after the two previous genes, and however, this order can be reversed if neurological features are present. However, because this is not a part of insulin gene related PNDM. Similarly, we may prioritize SUR1 gene testing when we see very large variability of phenotypes in the family. For example, PNDM, TNDM, relapsing neonatal diabetes, and permanent diabetes in childhood or adulthood. The consequences of the SUR1 related PNDM are as follows. The attempt to switch from insulin to sulfonylurea is justified, and in most patients it is successful. We should inform the patient or the family about this fact. This gene, however, is highly polymorphic, and there exists a variety of its sequence differences associated with PNDM, and it is very important that the parents of the proband are available for testing, because we need to verify that the variant identified is de novo, because this is a very important piece of evidence that this is diabetes causing variant. When you see that the parents are free of this and the affected individual is a carrier, de novo mutation, I would say de novo diabetes, so this is important. And we should be aware that most of PNDM cases could be explained by mutation in the KCNJ11, insulin, and ABCC8 genes. And this is a schematic presentation of the procedure of diagnosis and the procedure of treatment in PNDM. And in general, we can divide this figure into two panels. I would say the panel shown on the left-hand side, isolated PNDM, and a panel shown on the right-hand side. Panel where we see PNDM with ident or dent, meaning with neurological features, or some very rare PNDM forms with specific clinical features, as I said. So if we are dealing with non-syndromic PNDM, we should initiate testing for KCNJ11, and if negative, move on to insulin and ABCC8 gene. And for potassium channel subunits genes, may use sulfonylurea. Usually high doses are required. For insulin gene, however, insulin therapy is required. As far as the PNDM in consanguineous families, we should screen for insulin gene, the proinsulin gene mutations, because it happens that this mutation occurs in consanguineous families in recessive mechanism. And also we should screen for GCK mutations, and this should be prioritized if we see in parents impaired fasting glucose and small increment on OGTT. And we should be aware that in both cases we should use insulin therapy. For syndromic PNDM, if we are dealing with PNDM with ident or dent, we should test for KIR 6.2 gene, and if negative, test for sulfonylurea type 1. If positive, we may use glibenclamide, usually high doses. If not,